So my name is Dan Clinchot, and I would like to welcome you this evening. I am the Vice Dean for Education in the College of Medicine. I am also privileged to serve as the chair of the Department of Biomedical Education and Anatomy. And my role tonight is to welcome you to the 18th annual John C. Burnham Lecture. The John Burnham Lecture Series in the History of Medicine and Science was established in 2000 with gifts from his wife, Marjorie Burnham, to establish an annual lecture in his honor. The Department of History and the Medical Heritage Center of the Health Sciences Library jointly host the annual lecture. Since its inception, 15 individuals have been honored as Burnham Lecturers. Our speaker tonight is the 18th Burnham Lecturer. So let me tell you a little bit about John Burnham. John Burnham was a leading international figure in the field of the history of medicine and science. He wrote more than 80 major scholarly works, many of which have been reprinted and are considered classics. He also wrote 10 books and edited 4. 2 of these have won prizes. 1 has been translated into Japanese, and 2 have been translated into Chinese. Professor Burnham taught at Stanford and Claremont colleges, and he was a Fulbright senior lecturer in Australia at the universities of Melbourne, Tasmania, and New England. He also served as the Tolman Visiting Professor at Bowdoin College. In 2002 to 2003, he was a visiting fellow at the Robinson College in the University of Cambridge. He served as president of the American Association of the History of Medicine and held many other offices in scholarly organizations, both in the United States and abroad. He was a fellow of the American Association for the Advancement of Science, and he was the 2014 recipient of the American Association of the History of Medicine Lifetime Achievement Award. Dr. Burnham was a research professor of history and held a courtesy appointment in the Department of Psychiatry at Ohio State and the College of Medicine. He was an affiliated scholar of the Medical Heritage Center, and we are grateful to his wife, Marjorie, for establishing his namesake lecture that will keep his legacy alive at the Ohio State University and beyond. At this time, I'd like to introduce Professor Scott Levi, Professor and Chair of the OSU Department of History, who will introduce our speaker for this evening. And welcome to all of you.
Thank you very much, Dr. Clinchot, and good afternoon. On behalf of the Department of History, it's my pleasure to introduce you to our 18th John C. Burnham Lecture in the History of Medicine and Science, Entangled Bodies, The Challenges of Living with So Many Medical Interventions, by Dr. Robert A. Aronowitz, the Walter H. and Leonore C. Annenberg Professor in the Social Sciences and Professor and History and Professor of History and Sociology of Science at the University of Pennsylvania. Dr. Aronowitz is a physician and historian of medicine and science. He researches the history of 20th century disease, epidemiology, and population health. Prior to pursuing medicine, Dr. Aronowitz received his BA in English literature from the University of Michigan, which I hesitate to pronounce the M, but the University of Michigan, his MA in teaching English as a second language from Teachers College at Columbia University, and he completed a few years of graduate study in linguistics at UC Berkeley. After realizing that linguistics may not be the right path, he began to gravitate toward the medical profession. At the urging of his then girlfriend, now wife, he applied to the Yale University of Medicine, where he received his MD in 1985. He then completed his internal medicine residency at Pennsylvania Hospital and was then a Robert Wood Johnson Clinical Scholar at Penn. Even as his pursuits in the medical sciences deepened, Dr. Aronowitz maintained a strong, persistent interest in the humanities. Before starting his present position, Dr. Aronowitz was an attending physician at Cooper Hospital and taught at the Robert Wood Johnson Medical School at Rutgers. At Penn, Aronowitz was the founding director of the Health and Societies Program and co-director of the RWJ Foundation Health and Society Scholars Program. He was also a Guggenheim Fellow in 2017 and 18, during which time he worked on the project Medical Efficacy in a Highly Intervened In World, which explored the history of how Americans have judged the safety and usefulness of medical interventions. His first book, Making Sense of Illness, Science, Society, and Disease, came out with Cambridge University Press in 1998 and explored changing disease definitions and meanings in the 20th century. His second book, Unnatural History, Breast Cancer and American Society, came out with Cambridge in 2007. It's is a history of breast cancer in American society from the early 19th century, with special attention to patient and doctor decision-making and the experience of disease and risk. In addition to his many articles and his co-edited book, Three Shots at Prevention, the HPV vaccine and the politics of medicine's simple solutions. He's also published a third research monograph, Risky Medicine, Our Quest to Cure Fear and Uncertainty, which came out with Chicago University Press 2015. All are related to the history of risk-centered medical practices in the 20th and 21st centuries in US and in Europe. Please join me in welcoming Dr. Robert Aronowitz.
Thank you very much. Thank you, Scott. Can you hear me? For that very generous introduction, and to Amanda for handling all the logistics, and for everyone at Ohio State for arranging this talk, including the Burnham family. Thank you. So this project has been gestating for a long time. Like most everything else I've done, hold on one second here. It emerged from medical experiences that disturbed or bewildered me. And I'll start with just one of the many kinds of anecdotes that motivated this particular project. One of my friends about 15 years ago, at age 65, was diagnosed with prostate cancer. In the typical way people are diagnosed today, after a blood test, the PSA test, prostate-specific antigen, was positive. And my friend was, is and was an academic, and he reviewed all the current medical literature by himself, and he came to the conclusion that he should have surgery, mostly on the basis of a single study that in the pre-PSA era, before the PSA test was done, which followed men who had surgery and no surgery, and over time there seemed to be a clear survival advantage to the men who underwent surgery. So he was nevertheless very surprised and regretful when a few years later there appeared two randomized controlled trials done in the PSA era. Can you hear me? Am I not projecting, or is it better? Usually my problem is my Brooklyn accent and fast-paced talk, not projecting, but we can have all these problems at once if you want. Anyway, he was very regretful when he saw when he read these two studies that showed in the one case, there was no benefit to surgery over what's often called watchful waiting or active surveillance. There's lots of euphemisms for basically not doing surgery or radiation. And the other study showed some benefit in mortality, but at a terrible cost in impotence, incontinence, and other problems. And at the time of my friend's initial decision, I had voiced some skepticism of the evidence at the time. Basically, I explained to him, or I tried to explain to him unsuccessfully, that cancers, even if they look like the same cancer by stage and size and whatever, that are detected by screening, have a better prognosis. The epidemiologists have a name for this. It's called length time bias. But with time, and this is sort of the genesis of this project, I came to believe that my friend's regret didn't just result from a specific bias, but from some assumptions like a cancer is a cancer, a disease is a disease, independently from how we find, name, and diagnose it. And his situation, from my perspective, is one of the many where evidence needs to be interpreted carefully in the light of how our bodies and our knowledge of our bodies are being transformed by the intensity of diagnostic and therapeutic interventions. And so I've been trying to define this general problem and make sense of it. And let's see here. Okay, I have to get used to this, the way this slide is working here. My argument goes like this, I think it's relatively straightforward. Powerful, and I should warn you, there's medical history in this talk. It comes in a couple of places, but well, I'm old to do whatever I'm old enough to do whatever I want. I guess I've always been doing what I want. And there's in this book I'm writing, there's 4 case studies that are historical case studies, but I'm mostly going to present the general overview, a creed a course almost of like what's bothering me and the general outline. And I'm happy in the Q&A to give you some more historical detail. Anyway, the general argument goes like this. Powerful medical interventions are rapidly and widely diffused. Bodies and diseases as a result are transformed, leading to challenges for translating aggregate knowledge to the care of individuals. And I'll explain what I mean by that in a second. And other challenges, such as distinguishing the effects of disease from intervention, greater dependence on interventions, and resulting feelings of vulnerability, which cause, along with other factors, paradoxically, an increased demand for more interventions. Now, let me add a few clarifications and caveats before some of you think I'm just an anti-medical Luddite or something. First, just define translation. I'm really focusing on the last step in a long chain of what's sometimes called in the biz bench to bedside chain of events. I'm talking about this kind of the last stage of that, how clinicians and consumers and patients apply knowledge from clinical experiments and medical knowledge to individual diagnostic and therapeutic decisions. My focus, just in terms of terrain, is on advanced Western societies and chronic medical conditions and their often complicated medical management. My project does have a lot of implications, I believe, for places where there's not a whole lot of healthcare infrastructure, especially poor regions of the world, but I'm going to say little about this in the talk. Lastly, I don't want to be misunderstood as being anti-medical intervention or a Luddite, especially when we're still in the midst of a deadly global pandemic where politically manipulated skepticism of vaccination and other effective and necessary public health measures remain a terrible problem. I'll situate my argument in a moment, but let me give you a little preview of the talk. No? Okay. I'm first going to situate the project within existing approaches, give you a little snapshot of the highly intervened in body. I'm then going to go kind of deep into some of the drivers, the causes of the translation challenges I'm mostly interested in tonight. And then I'll make a couple of gestures to some other consequences beside the translation challenges. And if I have time, how much time do I have actually? I don't know. I'll try to answer the so what question, some implications for policy, training, et cetera, though I'm still working on those. Okay. My project's in conversation with some very well-developed critiques of Western biomedicine, such as, the harm of medicine is as old as medicine itself, what's sometimes called iatrogenesis. The problematic expansion of medicine, what sociologists call medicalization. There's a lot of current reform movements within medicine. You might lump them under the title too much medicine. There's a movement to prevent overdiagnosis. There's an initiative by the American Board of Internal Medicine called the Choose Wisely campaign. And there's an increasing impact, especially under what's happened with COVID, of the impact of coexisting medical problems, what's called comorbidity. But there's a gap in this literature, I think, that I'm trying to solve and fill and make some contribution to, which is the issue of complexity of decision-making, of navigating in a healthcare system. Most people are concerned about, understandably, with the cost of medicine, with the physical harms and effectiveness of medicine. But complexity itself is not thought of as like an endpoint in a way. For good reason, it's very difficult. It's complex. But that's a lot of what my focus is on the talk today. Okay. And I'm especially interested in those aspects of complexity that didn't just fall from heaven like manna, that are man-made, that are contingent, that we can do, that we have some control over, that we might be able to do something about, or not. Okay, so let's pivot to a snapshot of the highly intervened in body today. I think it actually was somebody in the audience or I was talking to before quoted back to me all these facts. So I guess it was in the brochure or the abstract of the paper. And this is, I can and I do go on and on about the facts and figures, but I think most of us get what I'm talking about. But just if you don't understand this, the average American has 3 visits to a physician per year. Almost half the population visits an emergency room. The average American fills 12 new prescriptions for medications, including an antibiotic prescription in a year. The average American has 9.2 lifetime surgeries. And, I think there's some number, it's not out there, that within the last 3 weeks, something like half the Americans have had an acetaminophen Tylenol containing product. Let me see this. Now, okay. Got ahead of myself a little bit. Yeah, this is just a slide showing the rate of change that, some people believe there's like a doubling of the number of outpatient prescriptions every 20 years. Okay. All right. And how does this lead to challenges for knowing what's effective and safe for individuals? This is the main translation thing that I'm going to be talking about today. Now, my daughter's a philosopher, and when I went over this talk with her, she encouraged me to use this sort of graphics of conceptual schemes. We'll see how this works. What these boxes mean is basically that I'm focusing on the ways we do research on the safety and efficacy of new interventions and regulate them. That's like the box all the way toward your right, right? And then their impact on clinical practices, the stuff in the middle box, and the resulting challenges to translation that the end game of translation, what's effective for you or safe for you as the individual taking it. There's lots of factors outside these boxes, the role of capitalism, political influences, underlying values. But let me begin with the role played by 2 prominent features of modern biomedical research and regulation. What I'm calling the global trials with naive bodies and the use in almost all initial research on the safety and efficacy of interventions, what I'm calling surrogate markers and short duration. Okay. So, okay, this is somehow not going where I'm supposed to go. Okay, I guess it's a little problem on this list, but I know what I'm talking about here. What I meant by the gap between research subjects and highly intervened in patients is that most of you might not know this. Is I don't think it's not many doctors and many doctors don't understand this, but a lot of our evidence and knowledge for new drugs especially come from clinical trials that are done on a globalized scale by contract research organizations. And they're constantly in the search for what they call in their business, treatment naive bodies. The idea is that if you can find bodies that aren't on 9 drugs, and are getting the initial medication for hypertension or whatever it is, the problem is it's going to be much easier to see figure to ground, noise to signal to noise ratio in it. And it's also cheaper. And there's also ways in which you can fudge the ethics of things when you're doing, unfortunately, when you're doing trials in developing countries. There's also a series of transactions that often happen where in exchange for being research subjects, doctors get credit for being researchers, other kinds of necessary medications gets transferred anyway. And sort of behind the curtain, so to speak, for a lot of medical knowledge is this global clinical trial industry. And they're often using proxy outcomes. To get a drug, to get something approved in real time, you often, if you're doing something like a study of cervical cancer, prevention with a HPV vaccine, you're not going to wait 20, 25 years. You can't do a study and see that result. You have to use something like cutting down HPV infection. It's not, it's almost a necessary evil. And because these are often pharmaceutical sponsored trials, and they want to get the results quickly and get patent protection, there's often short time horizons. Approved drugs, devices, and practice later meet people, that is you guys, people like us, who have many comorbidities and have a long history with past and concurrent treatments, and whose bodies are, and this is a little hard to wrap your hand around, as a consequence, more idiosyncratic, that is more different from each other than, as well as being more different from the research subjects, and even different from bodies in the past. And this leads to translational challenges and other consequences, including increased adverse drug reactions. Now, of course, I'm not saying this is the only driver of this, but it's pretty astounding when you look at, this is data from National Center for Health Statistics, that there's a doubling of ER visits in 7 years from the early 90s to the late 90s. This continued as well. The number for adverse drug reactions, kind of an astounding number. Of course, there's more drugs around, but this is not a simple monocausal claim I'm making, but I think this, in some sense, drugs are meeting bodies they've never met before, new drugs, especially given the system of how knowledge production works. Okay, so that's one challenge, the challenge of where the research comes from. Okay, a second, one source of the translation challenge. Another, I now want to turn to a couple of what I think of as self-reinforcing cycles that drive the rapid introduction and diffusion of medical interventions. Cycles that need to be understood as drivers of translation challenges, because the sheer number of interventions is, in some sense, the issue here. And all those things in the box now become relevant to the self-reinforcing cycle I'm going to explain in a second. And what happens, and what I'm going to try to convince you of, is that there's a self-reinforcing cycle between the conditions prevailing in initial research and regulation, the things in the box on the side, and our increasing reliance on phase 4 study to know what's safe and effective. Now, probably a lot of you don't know what phase 4 is. So the people who develop medical knowledge and do especially the initial research to get things approved, divide clinical trials into phases 1 through 4. And I won't bore you with 1 to 3. It's testing on animals, it's looking for toxicity, it's doing clinical trials. Phase 4 is the real world, or sometimes in the farm business, the post-marketing world. After something's actually in, the data is collected. And I'm claiming, and I think with good evidence, that there's increased reliance on what this phase 4 study. And that drives actually more drugs and devices and practices introduced with not the most ideal conditions. And I call this the buy now, pay later cycle of diffusion and regulation. And here's what I mean by that. Drivers of fast approval lead to more reliance on this phase 4 data for evaluation of safety and efficacy. At the same moment, the promise that, and the drug companies literally promise this when they get drugs approved, to do phase 4 evaluation enables different elements of fast approval. A recent controversial example, maybe you've heard about this, is all over the papers. The FDA initially did a conditional and controversial approval of this Alzheimer's drug, Aduhelm. But they did it, the fine print was contingent on phase 4. So that's how they kind of came to an agreement to do it. Well, we'll figure out what happens in the real world. And there are actually, this is a permanent state of affairs in certain things like new devices, which if they're regulated at all, if they're substantially, and that's a subjective judgment, similar to existing devices, the only evaluation that happens is phase 4 evaluation. And just if you want to leave here depressed, often my students, and I have an ex-student here in the audience, it's so sweet to see her, often ask me, like, how are surgical practices regulated? And I tell them they're not. You can fiddle around and do something different, and nobody's watching you, or you don't need approval for it. So And let me go on to another self-reinforcing cycle. And this has to do with the role of hastily introduced interventions that ultimately result in increased demand for interventions. And I'll explain this in a second. The fast pace of an introduction of leads to changes in apparent epidemiology that changes the belief in efficacy and safety, which then leads to more. This is a self-reinforcing cycle, more introduction. And I'm going to illustrate this with the history of prostate cancer. This is one of the times I'm going to, mostly the post-World War II history of prostate cancer, though the chapter in the book that I'm writing starts in the late 19th century. So the cycle I'm calling the title of the slide, a looping effect. That's a term from philosopher of medicine and science, Ian Hacking, and it's well illustrated by prostate cancer, which went from, it had a dramatic transformation, went from a rare and deadly diagnosis in the early 20th century to a diagnosis given to hundreds of thousands of American men yearly currently. And this looping effect goes like this. PSA screening, my friend had, the introductory anecdote, was launched and widely diffused in the 1980s without robust evidence at all. And, in the book, I go over the way it was unregulated. And this leads to more diagnoses. And this is uncontrovertible. You just look at when it was introduced. These are cancer incidence rates. Incidence is the number of new cases in a year. And in a very short period after the PSA test was launched, the incidence of prostate cancer doubled. That's the top curve over there. Higher prostate cancer incidence with constant mortality meant lower case fatality and better survival. And again, I don't want to, give a whole course in epidemiology here, but the 5-year survival rate of cancer you often hear about, or the inverse of that, the case fatality, is simply a ratio of the number of people diagnosed over the amount of people who die of something around it. And if you increase the number of people diagnosed and the mortality is constant, that's just a null effect. You assume nothing is happening, no effectiveness. You will necessarily have better 5-year survival and a better case fatality rate. And just to show you this in prostate cancer, in the 1970s, before PSA, the 5-year survival rate, as recorded by the SEER database of the National Cancer Institute, the 5-year survival was pretty good for prostate cancer at 69%. Now it's an astounding 99% 5-year survival rate. And there may be some effectiveness towards screening and treatment, but you can, if you want, you can explain this effect solely on the basis of our amount of diagnosis. These changes encouraged a belief, like, for my friend, in a belief in the efficacy of screening and radical treatment. And belief in the efficacy drove more patient and physician screening and diagnosis and treatment. So it's a kind of self-reinforcing autocatalytic, choose your metaphor thing that happens, that has happened, certainly with prostate cancer. Okay. The fourth driver of these translation challenges I want to talk about is the role played by the fast pace of technological change and diffusion in undermining straightforward translation. And I'll illustrate this with a quote from a 2015 consensus statement that reviewed the evidence and safety of screening mammography. And this group concluded, the working group recognized that the relevance of randomized controlled trials conducted more than 20 years ago should be questioned, given the large-scale improvements since then in both mammographic equipment and treatment for breast cancer. More recent high-quality observational studies were considered to provide the most robust data with which to evaluate the effectiveness of mammographic screening. And they recommended some recommendation that allowed for screening women under 50 for prostate cancer. This may be gibberish to you. Let me kind of explain it. Basically, they're saying, yes, the really good studies in the past showed no benefit, but now we have new gizmos. We have better ways of screening, better machines. So we're going to discount the old information around it. And I'm trying to document this across medicine. And what I'm trying to explain is, or call attention to, is that there's a rapid and often evidence-free techno-practice change on the ground is constantly undermining the relevance of even recent older evidence. Fast-paced diffusion can create a kind of antegrade amnesia, an inability to form stable pictures of the recent events. I just gave a talk at Cambridge University, and there was a sponge that someone was promoting to detect Barrett's esophagus, a kind of cancer. A really interesting, perhaps important development. And somebody asked her about randomized trial data and she said, well, we've got to use these short endpoints and proxy endpoints, because if we start testing this and we follow people for 10 years, there'll be sponge number 2 and sponge number 3 and sponge number 5, and it won't mean anything, our study on sponge 1. So researchers really feel this antegrade amnesia effect that I'm talking about here. Finally, the last driver of translation challenges I want to talk about, and this is going to get us into a little bit of medical history, follows from the great amount of research within practice, especially those parts of advanced medical care in which research is inseparable from everyday care, as is the case in a great deal of oncology practice and also in intensive care, but it's actually all over medicine. And if you remember my phase 4 idea, if you think about your data being used, which it is, for research purposes, we're all living in this world where research and practice are, in some sense, inextricably combined. And I want to talk about the translation challenges. And to do this, I'm going to talk about a prominent place of entangled research, improvisation, and care, and that's the resuscitation of newborn babies, especially premature babies. Perhaps, in fact, I talk about the highly intervened in body, the entangled body. Probably the most highly intervened body today is the premature infant. It's a kind of body that historically began in the 1930s. And it's one dependent on technology such as the incubator, but also administrative changes like the presence of pediatricians in the delivery room and widespread use of prognostic scoring like the APGAR score. And just by way of background, the incubator, first displayed on over here, on your right, was first displayed as a freak show with neonatal premature babies inside them at attractions like the New York State World's Fair in the 30s and on Coney Island, not far from where I grew up. And it was quickly modified to the more familiar on your left technology of the modern medical incubator that became central, maybe the most central technology in the specialized neonatal intensive care units that allowed the resuscitation and survival of premature and sick babies who would have otherwise died. Now, as most of you know, or maybe some of you don't know, by the late 1940s, very soon after this technology was incorporated, it became clear there was an epidemic of bilateral blindness affecting up to 10,000, blinding 10,000 premature infants in the first couple of years of incubator use. It was first called retrolental fibroplasia. Now it's called retinopathy of prematurity. And it led to intensive research and near panic among the emerging, can you see okay? Emerging world of neonatal intensivists. An underlying question that's bedeviled this highly intervened in body, the premature neonate, was whether RLF, I'll call it, was iatrogenic. Hold on, what happened here? Or an unavoidable price being paid for by the improved salvage of very premature infants. That's a question that was raised contemporaneously in a medical article. However, by the early 1950s, not by clinical trials, by clinical experience of modifying oxygen use, there was a consensus that supplemental oxygen was the culprit. Maybe not the sole culprit, but the main culprit in this blindness. Stevie Wonder was blinded in Chicago in a hospital. He was born premature with RLF, now retinopathy of prematurity. Now, over the 70 years since ophthalmologist Theodore Terry described RLF, there's been intensive clinical experimentation within practice of supplemental oxygen and other interventions. But arguably, we still don't know the right strategy. And I just cut some quotes from medical review articles from 1940s to the present, and they have a similar theme. In 1946, Terry himself said, a common exciting factor is related to premature birth and incubator life. It seems logical that exposure to light is still the leading factor. People didn't know. Something about the incubator could have been the light. Some people thought we had ways of just seeing the infant and just intervened in more. But oxygen, anyway. And at the time he said, yet no clinical and experimental finding strongly supports this. William Silverman, an incredible pediatrician, neonatologist, whose work I rely on to develop this case study, wrote in 1980, after the oxygen had been identified, to this day, that is 1980, when oxygen is administered to premature infants, they are exposed to the intertwined risks of brain damage, death, and RLF, with nothing more than an authoritative guess as protection. Fast forward to the 2010s, one neonatologist writes, it's amazing that we've been doing neonatology for so long and still don't know what the oxygen level should be. And just 2 years ago, someone wrote, titrating a sweet spot that allows for maximum survival and minimum ROP, that's retinopathy of prematurity, based on the age of the infant, their gestational age at birth, and other factors, still eludes physicians. So I want to focus on this, like, why we still don't know thing, and connect it to the challenge of research done within practice. And I'll do this by briefly touching on 2 episodes that illustrate each a different translation problem associated with this entanglement of research and practice. And they are something called the Kinsey experiment, that's shorthand for one of the first cooperative trials of pediatricians that was done in 1955, and a whole bunch of studies that were lumped by acronyms like SUPPORT, COT, and BOOST that were done in the early 21st century and reported in the 2010s. First, the Kinsey trial. And I'm calling this the perils of adaptive designs. And I'll explain what I mean by adaptive designs in my discussion of the study. In order to adapt to the fact that by 1955, when the trial was actually done, that almost every clinician, neonatologist, believed that oxygen was the culprit. And oxygen use had already been restricted in practice. Nevertheless, they felt there was a need to do a randomized trial to see if this was really what was going on and whether oxygen restriction was effective. But to adapt to the, what we sometimes call in the business equipoise, or the lack of equipoise, that if when physicians do a randomized trial, there has to be true uncertainty. And you have to believe that this experiment itself is not going to harm babies. They adapted, this is where the adaptation comes in, the trial to the needs of the baby being resuscitated. And essentially, from the first 3 months, babies, this gets a little technical here, but for the first 3 months of this study, there was a randomization. One baby got what they call routine care. Routine care at the time previous was giving babies 50% oxygen and more if they looked like they were struggling, to what they called oxygen restriction. On my slide, it says OR, which was allowing the clinician to use just as much oxygen as little as they could, based on how the baby looked. They couldn't measure oxygen the way we can today with my Apple Watch very easily. They had to actually stick people it was not clinically possible to continuously modify them for oxygen. And they decided if they would look at both blindness and mortality at 3 months, and if the mortality was no worse in the group that had restricted oxygen, then all the other babies were just going to be assigned to the oxygen restriction arm. This was an adaptation to the ethical quandary that they really believed the oxygen restriction was safer around. And this is what they did. And this is what happened. After 3 months, there was no greater mortality in the restriction arm, so all babies subsequently got restricted oxygen. However, and this is where the difficulty, the challenge comes in, over the next few years, awareness emerged of the much higher mortality from lung disease among the kids who had oxygen restriction and death that it was associated with. So by 1970, two leading neonatologists could write, the picture seems to be one of unrelieved gloom. That's among neonatologists. We can claim the great decrease in the occurrence of retrolental fibroplasia, but at the cost or the great increase of the death rate, and which looms as a terrible cloud. And by the way, the first study was called an adaptive trial because you adapted the randomized trial to these things. After Kinsey, there were 50 years of no trials. This was like a disaster. Here you did a randomized trial, you thought you had an answer, and the answer turned out to be incredibly misleading. Instead, clinicians just don't do nothing. Neonatologists are incredibly devoted to the babies and trying to resuscitate them. There was 50 years that I characterize as tinkering, without any large but robust formal clinical experiments. And by tinkering, I mean small experiments within practice. Sometimes it's just one neonatology unit, like playing around with things. And these tinkering produced contradictory results, and there was literally no consensus. Babies would be treated differently at Ohio State, and they might be at Case Western, around it. There's still some of that. It was difficult to organize another randomized trial of oxygen strategies because beliefs had hardened, and the faith in a randomized trial to come to the rescue had been damaged. However, by the 21st century, after essentially 50 years of not knowing, those quotes that I gave, there was an incredible angst among the neonatology community. There was also technologically the availability of things like the pulse oximeter that you can buy at Rite Aid, and other practice techniques that allowed for 3 coordinated studies to be done with these acronyms: support, cot, and boost. And these were incredible studies. They were done with ventilators that were programmed in such a way that the physician they said the nurses and physicians were dialing them, but actually they were programmed to deliver either the low or the high end of what was considered the safe range of oxygen saturation for kids. Let's say the range was 85 to 95% oxygen saturation. Some babies got 85 to 88. Some other babies got 92 to 95. Okay. And you can imagine this is all the problems that went into making this trial. It turns out they had all these studies were done in 6 different continents. Each trial had multiple centers, some in Australia, New Zealand, Europe, and the US. And they used the same kind of format so where they could do meta-analysis. I don't know if you know what that is. Some people call it garbage in, garbage out science, but it's a way of bringing together studies, that to increase their statistical power, so you can see something and know maybe finally what's the safe and effective way to resuscitate babies. When they did this meta-analysis, they found that there was a lower rate of progression to retinopathy of prematurity by the lower range. However, at an incredible cost, or however you want to look at it, of mortality. More babies were dying. And babies, there was no sweet spot, so to speak. There was just this. And this, now to further complicate things, this is the second translation problem I wanted to get to with this long story, I'm sorry, was that in the US, an ethical controversy erupted when some whistleblowers, or self-styled whistleblowers, reported that in the informed consent material for the mothers and the families in this trial, they were not told that there was any risk of being in an experiment, and lots of things have been streamlined, so what was going on looked like regular practice and not like they were conducting an experiment. Now, this was done on purpose because they didn't want to scare away people from participating in this trial. And they also didn't believe there was any risks of being in this experiment, quasi-experiment. There was risks of getting high or low oxygen, but they didn't know what it was. And this was no different from ordinary practice, they said. So initially, the NIH censored Duke and all these programs and reversed their fundings. There was a counterattack by bioethicists and people in the trials. But again, another bad taste was left in the mouths of lots of people, and especially given the ambiguous result. And the main take-home message for you from this whole history of retinopathy of prematurity is that the entanglement of research within practice, which is promising in so many ways, and in some sense needs to be done, has led to a very contested gray ethical zone about informed consent, about the ethics of experimentation versus the ethics of therapeutics. Okay. All right. Those were all translation challenges. And I'm going to try to whiz through in about 15 minutes a couple of, just to give you a sense of the scope of this argument that I'm making, some other consequences beside translation challenges. So first I want to consider how the person experiencing the highly intervened in body, that is you and me, often feels very dependent on medical interventions. Among the many consequences that this vulnerability can lead to is, ironically, an increased demand for even more interventions. And this leads to another one of these self-reinforcing cycles that I talked about in the context of the first challenge. Okay. And I'm going to illustrate this from just, some people ask me, what's the data for your study? This is archival research in the case studies, but a lot of what this project is just things I've sensed and lived through as a person with a body, as a clinician, but also as a critic of medicine, in the sense of reading the medical literature against the grain. There's lots of things in the medical literature that are quite interesting that are not about the results. They're sometimes just side things. And this is like one of them, one of these kind of factoids that I find so revealing and fascinating, though it wasn't commented on by the authors of the study. And this comes from the prostate cancer prevention trial, which was a trial of a drug called finasteride, which probably a lot of the males in this room are on. It's an alpha. It reduces the size of the prostate and helps men my age pee better, versus placebo. It does other things too. And in this clinical trial, all the subjects, but this was a trial not for that. It's known to reduce the size of prostate gland and relieve some of the symptoms of benign prostatic hypertrophy. The question was, could this also be a help in cancer? Could it help prevent cancer? And that's what this trial was about. Now, the incidental result, this kind of reading against the grain finding I want to tell you, was that at the end of the study, all men were offered biopsy if they hadn't received one as part of the study. The way the study went was they got PSA tests. If they were elevated, they got biopsied, they got treated. But a lot of men never got biopsied in either arm because they never showed any signals of cancer. Outrageously and interestingly, over 75% of the men in the study, over 8,000 men, said they would like to have a prostate biopsy. Who in this room would like, women can't answer this, would like to volunteer to get a prostate biopsy? Probably none of us would. And what I think this is evidence of is this state being inside this study, which is in some sense, again, a mirror to the world we're all in. If you enter into the screening paradigm with prostate cancer, or exposed to so many tests, so many moments where you're waiting for the result to come back, the sense of vulnerability that I'm talking about, that it leads them to consent to a painful, risky intervention that promises, even if it might not, that once and for all tell them if they had cancer or not. I trace this in the book into a lot of other things. Women who come today who have breast cancer, localized, small, maybe invasive cancer in one breast, increasingly, almost doubling a rate every 5 years, are opting to have both breasts removed. It's called contralateral prophylactic mastectomy. The idea is the cure for breast cancer is having no breasts, in a way. And this kind of organectomy thinking, you can follow the logic through all of medicine. Okay, in addition to the vulnerability, another consequence I want to talk about is that among people who have experienced many interventions, they and their clinicians are often challenged to distinguish the effects that arise from disease versus those from interventions. And I want to elaborate on two consequences of this blurred disease intervention phenomena. It's contributed to a slow drift to defining and measuring the efficacy and safety of interventions by their impact on other interventions, and to more interventions generally. It's not on my talk, but it just popped in my head. My daughter, I mentioned to somebody, my grandfather, 4 years ago, when she was pregnant with my grandson, a study came out in the New England Journal of Medicine that almost immediately changed practice all throughout it. It showed that it in a randomized controlled trial, that women at 39 weeks who haven't yet delivered a baby would be better off if they got induced, medically induced. I won't go into the whole thing, how that's done. It wasn't reported anywhere that the endpoint, they looked to see if there were better babies or better mothers. There really weren't. What the endpoint that was there is that we reduced number of C-sections. That was the thing that changed practice. And this has become like, no one's noticed this phenomena, but all throughout medicine, the endpoint that people look at is not something like we might define as health in some naive sense, I would say, but the reduction of interventions. But you know what? Did I not get to this? Okay. I skipped over something, which I wanted to say something. First thing, this is not a new phenomenon, this challenge of distinguishing disease from intervention. And this is just a quote I like from a guy named John Paul, a Yale polio researcher who was just recounting what it was like to be in the polio wards in 1940s and 50s at Yale New Haven Hospital. And he wrote, many of the patients may not have had polio at the time of admission, but by the time the interns got through with them, they certainly were surrounded by all the earmarks associated with paralytic forms of that disease, along with a frightening thought that they might never be able to walk again. And what John Paul is talking about, this is kind of doctor to doctor talk, that people were admitted, they were put in iron lungs, they were given all kinds of prosthetic devices, and they looked like they had polio, whether or not the diagnosis was correct or not. Second, many interventions transform bodies. They produce changes that don't necessarily go away after the intervention, and which are often more profound and irreversible than captured by the common sense meanings of the term side effects and addiction. And just to give you a taste of this argument, this is something I read in the New Yorker. New Yorker had a profile of Ambien. They usually profile like Joe Biden or something, but they decided to profile a drug in it. And they quoted some doctor saying, and Ambien, in common with many other drugs, can be tricky for some patients to give up. Those who stop abruptly may experience quote unquote rebound insomnia that's worse than when they started. And they inaccurately assume, oh, my insomnia is really bad still. And then he laughed. It's actually a nice feature for a drug to have from a pharmaceutical perspective. And this transformation is true of many medicines, whether you're talking about insulin, which didn't just cure diabetes, but uncovered a whole new stage of disease of end organ damage, to antidepressants and other interventions. And elsewhere, and I can't develop it right now, I think our terms like side effect and tolerance are hiding a much bigger transformation of the body to a kind of hybrid disease intervention state. This blurring of disease and intervention leads to what's called prescribing cascades, paradoxical reactions, and diagnostic cascades. And I think these are all tips of an iceberg. Let me explain what I mean. There is a small medical literature on prescribing cascades. And what I guess it's pretty obvious from this graph. The idea is that somebody's prescribed an initial drug. It looks like there's a new medical condition that develops and another drug is prescribed. And this happens also with over-the-counter medication and I would argue devices. So, some classic examples are somebody's on an antidepressant or an antipsychotic antidepressant like Abilify, which is known to cause Parkinson-like syndrome. And that patient sees a doctor who may know that this is a side effect of the drug, but the person needs the drug, treats them for Parkinson's disease. And then, the anticholinergic that they're given produces toxicity, and that's produced with a procholinergic drug. It's one damn thing leading to another, and this is increasingly recognized. And I can't really go into it now, but this is not just a matter of drugs. It's a matter of surgery, over-the-counter drugs, and surgical practices. And you might want to call this intervention cascade. And it's the medical literature is very small in this. It's mostly among the elderly and with psychoactive drugs. And paradoxical reactions, which I'm not illustrating here, have a long history, but it's more or less focused on, again, in psychiatry, which is picked on by a lot of people. And that's when the drug not only causes another problem, but seems to cause the problem the drug is supposed to treat. And I guess the most famous example of this is the suicide risk of adolescents who take antidepressants. Okay. And this is finally something I kind of took the rabbit out of the cat already on, about this changing in the meaning of efficacy being the impact on other disease. That was what I was explaining to you with the C-section as the endpoint for why it's safe or better to do inductions. But if you look at the medical marketplace, it's filled with drugs that are promoted and sold on TV ads as you're trying to watch the World Series, that they have lower, not that they're any better than for the patient in terms of their efficacy, but they have their risk of side effects are better than competing drugs. That's how Vioxx, a now off the market drug, was said to be better than aspirin. And when you look at interventions, Scott had said that I wrote a book about HPV vaccines. When you go into the history of the regulatory hearings for how this vaccine, which I believe you should take, by the way, whether it was cost effective or not, the cost effectiveness was very marginal when you thought about how this drug would affect the reduction in cervical cancer, in the US at least, where cervical cancer it's terrible, but it kills only, compared to like India, a much smaller fraction of people, like 2,000 women a year. However, the cost effectiveness of the vaccine is out off the roof when you think about the reduction in false positive pap smears, which costs them $3 billion a year. And increasingly, this is sort of at this aggregate macro level, how cost effectiveness is measured. Okay. Oh, I'm doing pretty well. Okay. I do talk fast, don't I? So I don't want to leave you with like nothing to chew on in terms of so what. You went to a talk and somebody told you how complicated things are. Though I'm struggling, I see the complications, frankly, a lot more easily than I can think about how to. And there's not an easy answer because there's so much good of modern medicine, and many of the interventions I've used in examples. And like I said, I'm not a Luddite, but nevertheless, I think there are some things to think about. And one is to slow down what might be called the evidence-challenged approval and diffusion of new interventions. And there's a couple of ways to think about this. One principle, an older principle of the first people who pushed randomized controlled trials in medicine, had a slogan: randomize the first patient. That is, when you have a new drug or practice, especially one that can fit into these feedback loops that I've been talking to you about, a preventative thing that can, when I hear about a new prevention thing, I shudder, because once the genie's out of the bottle, it's very hard to get the genie back into the bottle for it. Do it and introduce new things in the context of trials where you're studying their efficacy and safety. Don't let this history evolve like the prostate specific antigen test, which you only did a randomized trial 20 years after it already transformed what the disease was, in essence. Remember phase 4? I can give a quiz now that you know what it is. I think we have to do something about breaking that buy now, pay later cycle, where we're reliant on the promise of phase 4 surveillance. Every time I hear this, now many things like licensing the COVID vaccine, for example, in the middle of a global pandemic, there's a reason why you're going to have to rely on data later on. Even though a fairly good randomized trial was done, we didn't know anything about its effect on long COVID, on long-term things, whatever. And sometimes it's necessary, but a lot of times it's just for the ease of the pharmaceutical company. Again, students are often shocked when, and maybe you were shocked, when you realize that most drugs, the clinical trials to test their safety and efficacy, are run by the people who are making the drug. In other words, the fox is chronically guarding the chicken coop. I'm not going to, like I said, I wasn't going to critique the political economy of pharmacy, though I have one. I think at a more medium-term level here, a more realistic thing is have less reliance on this phase 4 surveillance. At least think about it more the way the promise, like this way this drug Aduhelm was approved on the basis of very shaky data with this promise. By the way, there's pretty good evidence that most of these drug companies never do that phase 4 surveillance. And by the way, you might ask, how do we know whether something has a side effect? Well, a physician or a patient has to recognize it as a side effect, then it has to be reported somewhere, and lots of things can just appear as problems without anybody quite knowing it. I got COVID, like probably a lot of people in this room did, and the Paxlovid, it's been in the news a lot. It's just around the time the initial reports of rebound infection. Do you know what I'm talking about? I don't have to go into it. I think it's kind of commonly available. And using the logic of what I've been telling you right now, I knew that the bodies that were taking this drug now, especially my body, now that had been twice vaccinated, was very different from the bodies that were used in the first tests, which were done a year ago, a year prior to when Paxlovid was being promoted, that had not had COVID before, that had not received vaccines. So that's the first thing about it. But secondly, because of the kind of really systematic way side effects are not surveyed I assumed that if there were credible reports at a case level of rebound, it was probably a much larger phenomena, and which is turns out to be true. And again, getting back to this, like how we produce evidence and regulate new practices, I think we could use fewer proxy endpoints and longer durations in trials when it's reasonable to do so. But there's a lot of forces against this. There was almost, the US Senate passed 99-1, I think, the Cancer Cures Act, which prescribed all kinds of shortcuts for getting cancer therapies measured in an attempt to like not hold back on something that could potentially be life-saving. I understand the instinct, but I don't think we've recognized the costs of this kind of logic. I think we can support these slow medicine, what I'm calling slow medicine initiatives that are happening from within medicine, especially the Choose Wisely campaign of the American Board of Internal Medicine, which is basically, it's asking all specialty societies to say, there's 5 things you overdo, like publicize them, change the practices of like gastroenterologists, whatever, around it. And I like the fact that it's being self-generated by the medical world. I'm also pessimistic because it's self-generated by the medical world. Anyway, and preventing overdiagnosis is a similar movement. I think we need to support the social capacities for navigating and improvising, given the complexity and work of intervened in patienthood. Something that's only implicit in what I've told you so far, and I don't want to overwhelm you with all these different ideas, but we've come to believe in medicine that the randomized trial will solve everything around it. And as I tell you about all these translation challenges, we're actually, I'm going to get to this in a second, so I shouldn't take my point. I think we have a real problem there. And as a result, patients and doctors are constantly improvising. And yet we don't teach medical students. We don't understand how to, we've kind of neglected a lot of things in medical education that clinical heuristics for managing uncertainty that we need to, and supporting the cognitive resources that patients have to navigate the complexities I've been talking about. And what I am going to focus on in the, maybe I'll do this for about 5 minutes, this is about 20 minutes for questions. I think we need to make knowledge and teach skills relevant for the world we're actually live in, this entangled world that I've hoped I've convinced you we're unfortunately living in. And let me explain what I mean by that. One implication of the picture I've been showing you is that despite being an era of evidence-based medicine and promise of rule-based practice, clinicians and consumers have more, not less, reliance on what I'll explain in a second, I'm calling therapeutic rationalism and reasoning. And this is a direct consequence of the translation challenges I'm talking about. Despite the fact that we have more and more pretty good evidence for many things, when an actual patient walks into a doctor's office or you're faced with a choice about things, it's more unclear what to do, and there's less of a kind of cookbook answer to what to do. And what do I mean by this answer to this therapeutic rationalism and reasoning? And that's something that's long been part of clinical judgment, which is applying to clinical translation knowledge about things like disease and treatment mechanisms, the natural history. Unfortunately, the natural history of disease, the kind of thing that medical students learn and you pick up a textbook and you read today, it's the course of a disease in the absence of treatment. There is no disease now that's not treated. So it doesn't exist anymore. And we haven't replaced the old natural history knowledge with new natural history knowledge and just generally knowledge of prognosis. It's been very neglected. We need to know more about illness and healthcare behaviors. Part of this cycles, all those cycles I've told you about have to do with behavior and social science, and we need to understand how they work, and other elements of prognosis. I realize this, I'm going over a lot of I just want you to have some sense that I'm not a nihilist, and there's things to think about here as a result of this. And just to give you a little medical history, a little background, all of us, those of you who are medical trainees or just get advertisements from health system and talk about evidence and precision medicine and personalized medicine. You have to know that as recently as 1963, the model of good clinical judgment was something like this. I'll read this quote from an editorial from JAMA. The rational physician decides to treat his patient on the basis of the disease the patient has, its pathophysiology, its natural history, and the drugs that will combat the disease and how they work. He, by the way, it's he, because this is the world in the 1960s, learns all that he can about the absorption, metabolism, and excretion of the therapeutic agents he uses. In those cases in which he doesn't fully understand the mechanism of a drug action or know how effective, how it's been used in similar cases by others, the wise doctor seeks the advice of experts, either through consultation or by reading what they recommend. These procedures are elementary, but how often are they followed? Now, I'm not endorsing this paternalistic model, by the way. nor am I bemoaning the efforts at getting as much rigorous evidence from high quality randomized trials as possible. But I do worry that we've thrown out the baby with the bathwater, not investing in the kinds of knowledge and skill that's actually needed for this gap that I think is growing between the evidence that's there and the actual clinical decisions that people face. And, how do we fill that gap? How do we support therapeutic reasoning? I have a chapter in this book where I do a historical review of what I call clinician theorists of prognosis. People who thought very seriously about most of you think of the word prognosis, you're probably thinking, how many days do I have to live, doc? When you're given it. But prognosis is really the science of what's going to happen to a particular individual under the conditions that they're suffering. It's predictive knowledge overall. And we need predictive knowledge of especially this intervened in disease. Comorbidity, I think COVID has produced, there's all the stuff out there about comorbidities are leading to more, explain why there's different patterns of illness with COVID, whatever, but we have very little research. Almost all research is done on one disease and its outcome, not on the actual bodies that we have, which have both lots of interventions and lots of comorbidities. And this term that one of my medical school teachers coined, iatropy, just means toward medicine, but basically, we have very little understanding about how healthcare interactions with healthcare. Iatropy, basically, we were taught at Yale Medical School by this guy, Alvin Feinstein, that when we elicited a chief complaint from a patient, we should also figure out their iotropic stimulus. And it was a convoluted way of saying, you may come to a doctor because of chest pain, but the reason why you came is because your wife thought you were about to die, or you have back pain, and a medical student comes and talks to you, and you ask them, how long have they had the back pain? And you say, well, 30 years, well, why did they come today? And there's often an insurance reason or whatever. But these patterns of health-seeking behavior and why, which mediate a lot of these cycles that I talked about, need to be better understood and studied. Boy, I thought I was ending there. I had more things to go on, but maybe I'll see if there's anything you could ask me about in the Q&A. I'm just elaborating on what could be done to mitigate some of these translation challenges, some of which has to do with focusing on symptoms and suffering more than objective abnormalities and diagnoses. So I'll leave it at that and open to your questions. Thank you. Okay. So he had problems post-surgically with impotence that gradually got a bit better. I'll just tell you, but in terms of medical knowledge, this has nothing to do with short time intervals or proxy outcomes. But the first studies of prostatic radical prostatectomy that were done, the way they studied whether or not they caused impotence was a surgeon asking a patient, how's it going? And in an embarrassing situation with very vague terms. And of course it was underplayed in a way. But anyway, he did pretty well after a year around it. And it mostly changed his attitude toward other medical procedures, I would say. He's an economist by training and has a lot of faith in data. And I think he had a mind-opening thing about how contingent evidence is, how much it depends on the circumstances of the moment. And in medicine, how there's this, I think I convinced him that there's often a disconnect between a report, just take Paxlovid, it's okay, And mind you, this puts me in a very funny position because like I said, I believe this is question's going to come at me, so I might as well answer it right now. The general reason I can get up in the morning and work on this project is because I think trust is so important in science generally, in biomedicine in particular. But ignoring the complexities is not a way to have trust. That's sort of the strategy now. It's just shove it under the rug. Shut up and do what I tell you, kind of thing. And I if I assume someone is going to ask me about this already, but I think exposing how difficult these translation challenges are and other complications of a highly intervened in body is not to make everybody think that medicine doesn't know what it's doing, but to understand I think you need really, literally, if you have to face a choice about chemotherapy, a difficult management of a chronic disease, knowing how contingent, how difficult this off-the-shelf data is to apply to you as an individual is a necessary way of reacting and also trusting in medicine. Yeah, Jim. Yeah, yeah. Yes. Yeah. Okay. So, yeah, yeah, okay. So now, so you said you signed Susan Reverby's book, right? So when I said some whistleblowers went after, it was Susan Reverby and other people. So it's actually historians and some anthropologists who had been students of Tuskegee that literally felt this was a bioethical travesty around it. So I'll say this, like I think we've gone a little bit too far in how we have almost made like a god of some bioethical principles and have not kept up with the world that actually exists in a way. And the evidence number one is the older distinction between research and practice. It's almost been elided, in almost everything we do. I think what's more important is what do we know about the actual harms and risks of whatever we're doing, whether it's research or practice, and to assume that a clinician who's treating a patient has the best interest of the patient at heart, and the person who's doing research is Dr. Frankenstein, just interested in advancing their career and getting tenure, is crazy. That's not the world we're living in today around it. Mind you, Tuskegee has some blemishes too around it. Part of the historical stuff, which, when I, that goes into the prostate cancer research, is a studies that were, and I published 2 articles on this, and it's gotten very little notice. I have no idea why. That happened way before Tuskegee, done for prostate cancer among Skid Row alcoholics in New York, the Bowery, today's Lower East Side, where my son and everybody wants to live. And this doctor took these alcoholics, took them up to a newly opened cancer hospital up by Columbia, and operated on them, not with a biopsy with a needle the way we do it today, but literally cut out like a 2 centimeter by 2 centimeter bit of tissue to see if they had prostate cancer. And a number of these men did. And when I published this study, I hope this is getting to your point, but maybe I'm going a little bit on the tangentially. Like, I didn't want to just say this is another Tuskegee. Look, on poor, vulnerable people, you've just done this stuff. Either they couldn't possibly know what was going on without thinking about their benefit. It was that, but it also was a logic of thinking about a screening paradigm and a way of, today we're living in that world. This guy in the 1950s could only try to imagine, where 75% of those 8,000 men in that study got prostate biopsies, where millions of men, whatever. It's just not knowing what's correct and almost creating the conditions for not knowing what's right is an ethical problem, not just a scientific problem. And that's kind of not, that's sort of the other half of this bioethics criticism. That's kind of not, and we need that research. Those neonatologists have been experimenting or doing God's work, I think, in many ways. And it is an incredible problem if we create conditions by giving unnecessary paperwork to them and scaring the diseases out of these people for no good reason, so that they don't comply with the study, and we end up with results which are meaningless, and babies are being blinded or killed. That's like a serious problem. So there's a problem in the ethics, in the kind of some traditional ethicist, I think, point of view from my perspective. That's just my perspective.
I think this is a wonderful talk, and this gives me the opportunity, really, this gives me the opportunity to talk about Ohio State and prostate cancer, because I have prostate cancer. I was treated at Ohio State by wonderful urologists will recognize every principle that you brought out today. Every. Saved me from any procedures, any surgery, any radiology, and I'm feeling great. So, Ohio State.
Now, not, go Buckeyes. That, great that you met those doctors and that you, but I have to say, part of the chapter in this book that I look at a lot of people who were told by their clinicians, listen, you don't necessarily need surgery. Let's wait and look at this. The situation we're talking about is usually people that prostate cancer is staged with something called a Gleason score, and it's I don't want to go into it, but it's an interesting way of trying to predict who's going to really get serious problems, who not. And a lot of people who are found by screening end up with a so-so middling Gleason score that's relatively good prognosis around it. That's sort of what it is. And there's millions of men in this situation. And a lot of good, thoughtful scholars and others can say to somebody, especially if they're older, let's just wait and see. But for a lot of people, that wait and see is not first thing, it's not an absence of action. Every year, I don't know if you get, I'm going to put people on the spot and really medical picture, but every year people may have to need a biopsy for some aggressive urologists. They measure all kinds of tests and do ultrasounds, and it becomes a state of risk that people at some point, even if their doctors don't want to do it, say, enough of this, and want to have the surgery. So it's great about Ohio State, but it's if there's really no good evidence that screening works in this terms at a population level, I'm not saying people can do that without that, but I'm not sure it should be promoted like wonderful, which is kind of the current reality. Yeah.
I'm only a dentist, find them that I'm not a I'm curious, 4 years from now, right?
Yeah.
So the first vision of like the exam, that's
I'm 68. I had a little bout of a fast heart arrhythmia, so I actually wear an Apple Watch because I was totally symptomatic about it. And I had a yearly check with a cardiologist who was doing his thing, checking my cholesterol and everything. I'll order a PSA test. Are you on? And yes, I'm on. It was almost like an afterthought. So here I am at 69. The answer, I'm not 72 yet. 68. I'm totally committed to changing my tune with different evidence. And the evidence that matters here to me personally is something like there's a little, heuristic that sometimes comes in handy translated to the aggregate to the end, which is the number needed to treat, and when, oh, sure, I'm sorry. I'm so sorry. I hope you understood some of what I said. So, those two studies I said that bewildered my friend, the numbers have gotten a bit better, more favorable to prostate intervention since then, but it was something like you needed to screen 1,000 men to pick up 50 prostate cancers to save one life from prostate cancer at the cost of, 100 cases of impotence and, 20 cases of incontinence. So when the numbers look like that, I'm not saying, somebody who really fears prostate cancer and wants to avoid that one mortality, let them do it. I'm not against it in some ways, but I make the calculation that I'd rather not know. And because of this cycle of creating a risk state, what the urologists today recommend is there's nothing wrong with a PSA test. It's just information. It doesn't hurt you itself. It's a blood test. I'm already getting my cholesterol, they're just adding it onto it. It's not the information. And they also think, praise be Ohio State, they also think we've made clinical decisions our whole life. We're skilled at making decisions. Let's just get the information and let us, with you in a shared decision-making mode, figure it out. But I don't think the urologists are the experts in risk assessment or aggregate data analysis. So I think it's a problem. This like, let's just get the information and deal with it later. Not that what you're saying, but that's also part of my hesitation, to enter this cycle because of it. But, when my obituary says I died of prostate cancer, everybody will laugh. Yule Gibbons died on the side of the road after eating wild asparagus. I worry with magical thinking that something's going to undo me because of stuff I've published, but let's hope not. Yeah, sure. Okay, so overdiagnosis is overdoing it. It's not against diagnosis. It's the first point, and I think, yes, in many cases, it's part of those clinical principles I'm talking about. A lot of the importance of a diagnosis, if one can be found, is incontrovertible, around it, whatever. If the questioner, they're not here, was sort of saying, okay, let me get back to a little medical history. I told you that there were these hearings that were done in 1980s about whether to license this new PSA test or not. And there was a bunch of like clinical epidemiologists who were like the jury. And there was a guy from this new biotech firm, a clinician was working for them who didn't know much about anything, from Hybridtech, who was defending or asking for the FDA approval for this new test. And the guy said, when he couldn't show any evidence that it was actually going to be effective at curing or reducing the mortality of prostate cancer, said, you know what, patients just want to know, and doctors want to know. And this is at a time when the test was used to monitor whether the cancer was coming back or not, because it's basically the PSA and what's called the prostatic acid phosphatase, a test that was just almost as good that was used for decades before then, go up when you have bigger prostate glands, and cancer is more prostate gland too. But what this guy was saying was, and maybe this is part of the question here, we should allow it because patients want to know. Patients want to know even if there's nothing to do about cancer recurring, they want to know. And I have problems with that. I mean, certainly at the policy level, the aggregate level. I'm not saying any individual doesn't, but if we rationalize things in medicine because of their psychological benefit, and I find it very ironic that it's often the pharmaceutical companies, when they've shown no evidence of efficacy, they bring up this argument in many, many different contexts, that whether or not it actually changes the situation, you're not being realistic. You don't know what the doctor in practice and the patient in practice really wants. They want to know. I think we have to be critical about that. I'm not saying in an individual situation, I might just want to know whether or not I'm going to do anything with the information or not. I'm human, and I'm not sure it's so bad. But since the entanglements result, it's not just like, a little bad information or something you can't do with it. There's so many, if we understand all the consequences for knowing, when I hear a relative of mine saying, I went to the greatest doctor, I had some back pain and they ordered every imaginable test and a full body PET scan and whatever. And they're saying like, it's so great. They didn't hold back. It's crazy. There's so many other things that will come out of that, but I don't really know the actual force behind that overdiagnosis question. So, is there more, Amanda? I mean, you have to decide when you've had enough of me. Yeah. Okay. Well, I think he answered his own question in that point. I think I try to say in the talk, the surrogate issue that's the issue of using, like, you're interested in preventing cancer, but you can't wait 20 years for cancer to happen. So you use something that's correlated with it around it. I think it just has to be used judiciously and wisely based on what you think what knowledge of the natural history of disease is and what's being promoted. But when it's motivated to get just something marginally effective or not effective quickly into a market, it's a kind of epistemological malpractice, I would say. And the other thing about with surrogates, and the other thing was, the fox carting the chicken coop issue in terms of who makes guidelines. Yeah, of course, that's nutty. That's crazy. around it. But you could argue that everyone has a bias. Maybe the skeptic who makes his career being a skeptic is increasing their fame by publishing negative studies and things like that. So I'm not like naive to say, because someone has a potential conflict of interest, like their argument is wrong. I think you do have to look at it in the context of what they're doing and understand that conflict of interest is much more than just money. In a way, in fact, money is. As a historian, I was asked I was listening to an NPR show about the financial crisis, and some economists were talking about the cause of the 2008 thing, whatever, and they were responding to readers' questions about greed. And the person had some historical consciousness and said, you can't explain change by a constant, meaning like greed is always there. We had this new declining bubble that just burst in a way, whatever. You have to look at some more specific factors around it. So sometimes a little overemphasis, I find, like the analysis stops when somebody finds some financial conflict of interest. It's of course a big problem, but it's not the only problem. You done? All right, thank you. Okay. Send me all the smiley faces or whatever, it'll make me sleep better tonight. Okay, well, thank you, everybody.